Okay, opioids are also termed as, or you can also call them as narcotics or narcotic analgesics. Okay, narcotic analgesics. Okay, now the opioids and the non-opioid, the main difference is you are not using non-opioids very often in your home and something like that. Rather, you are using the NSAIDs. For example, you are using ibuprofen, diclofenac very often in your home, right? They are the painkillers and something like that. Okay, so the thing is, you are using the paracetamol. Most commonly, we are using the paracetamol. They are quite safe in the children as well, right? But they are not acting as anti-inflammatory. They are working for fever and pain. Okay, but we are not using the opioids or narcotic analgesics very often. We are using the opioids in hospitals mainly, and the reason behind this is opioids are quite addictive. Okay, so once the patient started on the opioids, we should have the point in our mind as a clinician that this patient might have the addiction further. Okay, and we will be having the problem in the de-addiction of the opioids. Okay, as far as those patients are concerned. So opioids are quite addictive. Okay, and on the other side, we are having several kind of side effects for the opioids. Okay, and the withdrawal symptoms might appear in the patients, and I'm talking about the addiction. The addiction can be too severe that the patient may die. Okay, if they will not be getting, if for a few period of time, for a particular period of time, the patient was taking the opioid, the patient was an opioid, and suddenly you told him to absorb the drug. Okay, we are not telling any kind of patient to absorb the drug spontaneously or suddenly, but we are gradually lowering the doses, and then we are stopping the opioids, right? But somehow the patient is not having the opioids at that time. The patient is not able to buy the opioids, for an example, if there is a case. So in that situation, the patient may die because of the addiction for the opioid. Okay, so before going into the detail for the opioids mechanism of action, let's talk about the normal scenario, what is happening inside our brain, because they are working on the pain receptors. Okay, pain receptors are nociceptors. Okay, pain receptor, nociceptors in physiology, we already know about this. So as the pain impulses goes from any kind of target organ to your brain, okay, they are taking the through the spinal cord. The impulses are going to the thalamus. Spinothalamic tract. Okay, ascending tract. Spinothalamic tract is for the pain and temperature. So one of the thing is pain, right? So pain is taken by which kind of ascending tract? That is the spinothalamic tract, which means from the spine, from the spinal cord to the thalamus. Okay, and from the thalamus it will be taken up to the cortex, right? And there the sensation will be known to the patient, right? Okay, not a patient, a physiological human. So let's talk about that. So first of all, let's say this is the presynaptic neuron. Okay, I'm talking about the spinal cord over here. So let's say this is the spinal cord, one part of a spinal cord. Okay, central canal is present over here. Okay, now this particular part of the spinal cord, okay, we are talking about here, and here I'm talking about the neurons. Let's say I'm talking about the spinothalamic tract. Okay, so one of the neuron is here, and this is the presynaptic, synaptic gap, and this is the postsynaptic. Here we are having the presynaptic vesicle, right? Presynaptic vesicle. Now in the cholinergic system, in the adrenergic system, we have already known that in the cholinergic we talked about the acetylcholine as a neurotransmitter. In the adrenergic we talked about the norepinephrine neurotransmitter. In the Parkinson disease we talked about the dopamine as neurotransmitter. Here we are having several kind of neurotransmitter. It may be norepinephrine, it may be acetylcholine, and mainly it is the glutamate. Okay, glutamate we have already discussed somewhere. Where? We have already discussed about the glutamate in last class, anti-epileptics, where we need to apply the brakes on the glutamate, right? Because it was acting as an accelerator for the irregular motor impulses coming from the brain. Okay, and we were stimulating the GABA in the anti-epileptics, right? Because GABA is the inhibitory neurotransmitter, right? Okay, we are having the glutamate over here. We are having one more thing, that is the substance P. What is the name? So this is the substance P. Okay, however, we are having the norepinephrine, acetylcholine also, but mainly these neurotransmitters we should know. Then we are having one more, that is the CGRP, and this CGRP is called as calcitonin G-related peptide. Okay, calcitonin G-related peptide. So these three neurotransmitters we are having inside the presynaptic vesicle. If we are talking about the spinal cord, we are talking about the pain. Okay, remember we are talking about the nociceptors. Fine. Okay, so here is the postsynaptic neuron, and we know that receptors should be present over there. So you know, NMDA and AMPA receptor, NMDA and AMPA receptor, we have already talked about those receptors in the epilepsy and anti-epileptic drugs. So let's say one of the receptor is over here. Okay, this is the, let's say this is NMDA receptor. Okay, NMDA receptor. One more receptor we are having, this one, let's say this is the AMPA receptor. Okay, then we are having one more. Okay, and let's say this is the neurokinin 1, NK1, neurokinin 1 receptor. Okay, neurokinin 1 receptor. And we are having the one more, that is for CGRP. Okay, that is CGRP, calcitonin gene-related peptide receptor. Okay, so we are having 4 kinds of receptor present on the postsynaptic neuron. So what will be happening now? This glutamate, whenever, look, simple rule is action potential, right? How the action potential comes? Voltage gated calcium channels will be opening up, calcium ions will be going inside. As the calcium ions will be going inside, this presynaptic vesicle, it will be fusing to the membrane of the presynaptic neuron, and then exocytosis will be happening. Okay, so this kind of thing we can see there, that it will be fusing, and then these neurotransmitters will be having way towards the synaptic gap. Okay, and once they will be coming over here in the synaptic gap, they are having the chance to bind to these receptors, right? Now what will be happening? This glutamate will be coming out from here. Okay, let's say this glutamate is present over here. This glutamate is having the chances to bind to the AMPA receptor and to bind to the NMDA receptor. Okay, AMPA receptor, AMPA receptor, and the NMDA receptor. Then what will be happening? So let's say there is the binding of this one. Okay, now NMDA receptors, okay, with the help of NMDA, as the glutamate will be binding to them, NMDA receptor can lead to the influx of calcium ions. Can lead to the influx of calcium ions. So if the calcium ions will be going inside, depolarization will be happening or repolarization? Depolarization, right? Okay, then we are having the AMPA receptor. Okay, here sodium influx will be happening. Again, depolarization. So pain sensation will be increasing. Pain sensation is increasing. Okay, then we are having, so this was the glutamate over here. This was what? Glutamate. We are having one more, that is the substance P. Now this substance P, let's say this is the substance P over here. Substance P. Okay, it will be binding to the neurokinin 1 receptor. If it will be binding to the neurokinin 1 receptor, what will be happening? It will activate the protein kinase C. It will activate the protein kinase C. And what protein kinase C will do? You know, usually this NMDA receptor, it is actually inhibited by the magnesium ions. It is actually inhibited by the magnesium ion. Which one? NMDA receptor. So let's say this is the okay, let's say this is the barrier kind of thing for the NMDA receptor found by magnesium ions. Okay, so magnesium ions are preventing the calcium influx. Okay, however, if the more and more glutamate will be coming, they're having the more chances to cause the calcium influx. However, magnesium ions are inhibiting that, or magnesium ions are preventing that. What will happen if the substance P will be binding to the neurokinin 1 receptor? It will be stimulating the protein kinase C. Protein kinase C is having the tendency to remove, this magnesium ion from the NMDA site. If the magnesium ions will be removed from the NMDA site, glutamate is having more chance to cause the calcium influx. Okay, so that is happening over here. So what is happening? Neurokinin 1 receptor will be stimulated by the substance P. It will be activating the protein kinase C. Protein kinase C will be removing this magnesium ion barrier, and calcium ion influx chances will be increased further. Understood this point? Okay, further we have talked about the glutamate. We have talked about the glutamate, we have talked about the substance P. Then we are having one more thing, that is the CGRP. So let's say this is the CGRP over here, calcitonin gene related peptide. Okay, this CGRP is having the chance to bind to the CGRP receptor. Okay, as it will be binding to the CGRP receptor, it will be activating some kind of gene machinery, and further it will activate the depolarization process from these receptors.
Sorry, what will be activating
CGRP neurotransmitter? It will be activating the CGRP receptor. As it will be stimulated, as it will be activated, then it will be stimulating some kind of gene factors inside the postsynaptic neuron. Okay, and with that, with the help of that, depolarization process inside this neuron will be increased further. Okay, so that is how the pain sensation will be attributed over there. Now what will be happening? So if these kind of things will be happening, pain sensation will be properly going to the thalamus, and then they will be delivered to the cortex region. Okay, those pain sensations who are not reaching up to the cortex, you will not feel the pain. Okay, for example, if general anesthesia is there, or if local anesthesia is there. If local anesthesia is there, that is the regional anesthesia. We have already talked about the local and general anesthesia. Now local anesthesia is also called a regional anesthesia, which means some kind of region will be it will be anesthetized. So in that case, what we are inhibiting? We are inhibiting the pain sensations. Okay, we are inhibiting the depolarization in that case, right? So in that case, what was happening? Local anesthetics was penetrating. It was lipid soluble, right? So it was going inside the membrane, and from inside it was blocking the sodium channels. From inside it was blocking the sodium channels. Now here what will be happening? We are having the opioids, okay, and inside the body some opioids we can give them, that is the exogenous opioid. If the drug we are giving, that is the exogenous or endogenous? Exogenous. We are giving that from outside. Now from inside also we are having some opioids. From inside also we are having some opioids. Now if I am saying inside our body we are having some opioids, that is the endogenous opioids, we should have some kind of receptors also for that. So we are having the opioid receptor also. So these opioid receptors are present over here. They are present on the postsynaptic neuron also, and they are present on the presynaptic neuron also. Actually this is the G inhibitory. Okay, G inhibitory, I is for inhibitory. Okay, we are having one more, that is the GQ, that is the stimulatory, and this is what inhibitory.
Even GS is stimulatory.
Yeah, even GS, yeah, that is also stimulatory. So this receptor, our opioid receptor, so this is the opioid receptor over here. This is the serpentine receptor. Serpentine means
Membrane.
it crosses the membrane 7 times. Okay, it crosses the membrane 7 times. For example, if this is the receptor, it crosses the membrane 7 times. Okay, why we are calling that a serpentine receptor? Serpentology is the study of snakes. Serpento means snakes, so it looks like snake. Okay, that's why we are calling that as serpentine receptor. So this is this is the G inhibitory receptor. If I am saying this is the G inhibitory receptor, which means it will be inhibiting something, and what it will be inhibiting, whenever they will be stimulated, they will be inhibiting this pathway. Okay, they will be inhibiting this pathway. So they will be inhibiting this depolarization process over here. Okay, so opioid is for that thing. Now, okay, so G inhibitory. Fine, so we are having one opioid receptor over here, let's say, and we are having one opioid receptor over here. Okay, that is also opioid receptor over here. Okay, and this is also opioid receptor. Fine. Now look, I am saying we are having some kind of endogenous opioids. So what are these endogenous opioids? Endogenous opioids are the natural, they are produced inside our body, and these are endorphins, enkephalins, and dynorphins. Okay, these are the endogenous opioids. They are having the tendency to stimulate these receptors on the presynaptic neuron as well as postsynaptic neuron, and they can inhibit this whole process of depolarization. So they are having the tendency, they are having the capability to decrease the pain sensation. So you must have heard that, in schools when we used to get beaten up by some kind of sticks or something like that, we were having some kind of threshold. So if you will be taking 10 sticks, for example, in your hands, then after that you will not be feeling the pain. Okay, because you will be reaching your pain threshold. So what is happening, these endorphins, enkephalins and dynorphins, they will be stimulating these receptors. Okay, so at till particular point of time you will be feeling the pain, and after that you will not be feeling the pain. Okay, so that kind of thing is happening. That is the best example which I can give, right? Okay, after that, so we are having these kind of things. I told you opioids are having the tendency for the addiction. Okay, so whenever the person is so much tired, they are having the pain and all these things, they took the opioids. Okay, however, we are giving them in the hospitals. Okay, we are not prescribing it very often. We are prescribing the non-steroidal drugs. They are also for the pain, fever, anti-inflammatory and all these things, right? What will be happening? They will be acting on these receptors. These are the exogenous opioids working like endorphins, enkephalins and dynorphins. They will be acting over here. They will be inhibiting this pathway. So the person will not be able to feel pain, and the person will be relaxing now. The person will not be feeling the pain. Okay, fine. So if the person is taking the opioid for that particular time, they will be enjoying the drug and all these things. Okay, they will be enjoying this process. And when the thing is, whenever you don't have to use the opioid, because you are having the endogenous, you don't need to take from outside. If the pain is increasing, for example, when the hospital, when the nurses are administering, when the doctors are administrating the opioids, whenever the patient is having the severe pain, one of the example of the opioids, we will be talking about the classification, that is the morphine, which is used quite often in the hospitals. Okay, when I was talking about the acute MI, I told you the Mona therapy, Mona and Sonam, remember? So in the Mona therapy, we were having M for morphine, right? Oxygen, nitrates, and then aspirin. Okay, aspirin also we'll be talking about that in the NSAIDs, non-opioid. So we are having the opioid over here. Why? Because the patient will be having the constricting pain behind the breastbone, behind the sternum. Okay, so for tackling that pain, we are giving what? Morphine. And how it is helping that patient? They will be stimulating these receptors, right? And then they will be inhibiting this depolarization process over here. And if the depolarization will be inhibited, with that, one more action is there. We are having the potassium channels. We are having what? Potassium channels on the postsynaptic membrane. Potassium channels. Okay. And what happens is, if the influx of sodium ion happens, or if the influx of calcium ions happens, we know there is a depolarization. Okay. If the influx of potassium ions will be happening, that will be leading to repolarization or hyperpolarization. If the action potential we are talking about, okay, let's say this is the resting membrane potential, and this is the threshold potential. What actually happens is you need to give the stimulus with the help of sodium ions, and then there will be the action potential. This was happening due to sodium ions, this is happening due to potassium ions. Sometimes what happens is there is a hyperpolarization. Yeah.
Repolarization, is it because of potassium entering or leaving?
It is usually due to potassium efflux.
Leaving, eh?
Yeah, leaving. So what is happening? Sodium influx will be happening over here. Potassium efflux will be happening over here. Okay, potassium efflux will be happening over here. In this case, what will be happening? All these things, they are happening over here, but inside it we are having the potassium influx over here. Okay, if the potassium influx will be happening, then what happens? Hyperpolarization kind of state is there. If some kind of tissue is hyperpolarized, it is very difficult for that tissue to depolarize now. Okay, and if it is very difficult to depolarize, which means it will be inhibiting this process, right? You need more stimulus to get the pain sensation now. Okay, so that's how it is working. So it is working on, first of all, it is inhibiting this depolarization process, and it is stimulating the hyperpolarization process inside this neuronal system. Understood? So you talked about the machinery, how the pain machinery is happening. We are talking about the nociceptors, right? We're talking about the nociceptors over here, pain sensation. Okay, so these were the endogenous opioids. Now let's talk about the classification of these opioids, exogenous opioids, right, in the form of drugs. So okay, so in the classification we are having by the way, before the classification, let me tell you about the receptors of the opioids. We are having three kinds of receptors for the opioids, and these were one of the receptor, that was mu receptor. Okay, this is the sign of mu. Okay, or mu in English, you can say mu. Okay, this is the mu. Okay, so we are having three kinds of receptors. Okay, and these three receptors are mu receptor, okay, mu receptor, kappa receptor, and delta receptor. Okay, so mu receptor, okay, mu receptor, kappa receptor, and delta receptor. Which one? Sigma receptor. Okay, we can use, but usually we are not talking about the drugs which are acting on the sigma. Okay, so that's why we don't use that term. Okay, so mainly we are talking about the three receptors, and among these three receptors we are talking about the mu mainly. Okay, so mu receptors they are sharing the location in abundant form as compared to kappa and delta receptor. Okay, secondly, most of the drugs, they are working on the mu receptor. Okay, so let's talk about the classification now. We will be more clear about the receptors then. So first one, we are having the opioid agonist. Okay, second one, we are having the partial agonist, partial opioid agonist. Okay, and third one, we are having the opioid antagonist. Okay, so opioid agonist, partial agonist, and opioid antagonist. Now in the opioid agonist, we are having several classes. So in the opioid agonist, I am talking about over here now. So in the opioid agonist, we are talking about the fentanyl. Okay, just now we have talked about one more drug, that was morphine. Okay, then there is trimipyridine, okay, also called as promidol. Okay, then we are having methadone. Okay, one more drug we can add over here, that is codeine. Okay, however, we are using the codeine as antitussive. Yeah. Okay. Fine. So this much drug mainly we are talking about in the classification of opioid agonist, and you can say these are the mu agonist, mu receptor agonist, because mainly they are working on which receptor? They are working on the mu receptor. So they are stimulating the mu receptor over there. Okay, fine. So if we talk about the actions, okay, we will talk about the actions later on. Let me talk about the partial agonist also. Partial agonist, you need to remember one drug, that is the buprenorphine. Buprenorphine. Okay, so what buprenorphine is doing, why it is partial agonist, which means it is stimulating the mu receptors. Okay, it is stimulating the mu receptors, but they are not having much stimulation on the kappa and delta receptor. Rather, it may inhibit the kappa and delta receptor. Okay, so they are having the mu receptor. Yeah.
What of pentazocine?
Pentazocine is a drug which may act as mu agonist, because it may act on mu receptor, and it can be classified under the category of this one, opioid agonist. Okay, so they are having the similar mechanism of action as compared to this one. Okay, so pentazocine can be classified under this one. I think it is included in the classification of that university textbook also. So this is the drug. So buprenorphine, what is it doing? Why the buprenorphine is very helpful? I told you there is a chances for the addiction purpose. So if the addiction is increasing in the patient, you can give this drug buprenorphine. And buprenorphine, why it is giving in most of the patient? Because for the withdrawal symptoms. Now, what are the withdrawal symptoms, for example? How to identify the withdrawal symptoms? If the patient is having the sweating, the patient is having lacrimation, okay, the patient is having more salivation, okay, the patient is having more bradycardia. So these are some kind of symptoms in which you can identify that this patient is having the withdrawal symptoms from the opioids. In those withdrawal symptoms, we are using the buprenorphine. One more drug we can use, that is what? Methadone. Okay, so methadone and buprenorphine can be used in those cases who are having the withdrawal symptoms from opioid drugs. Okay, withdrawal symptoms from opioid drugs. Okay, fine. So withdrawal symptoms, you can say that more and more salivation is seen in the patient, lacrimation is seen in the patient, sweating is seen in the patient. Okay, these are the signs for the withdrawal symptoms. Fine. Okay, in the opioid antagonist, we are having the drug that is naloxone. Okay, we are having the drug one more, that is naltrexone. Okay, naloxone can be given intravenously in the patients, and following that we can give naltrexone, that is given orally. Okay, so what happened is, naloxone is just opioid antagonist. Okay, they are working very fast in the body. They are very helpful in detoxifying the patient who are suffering from the opioid poisoning or morphine poisoning. Morphine is example of, look, if we are talking about the opioids, we are talking about the morphine usually. Morphine we are using on very large number of bases. Okay, in every hospital we are using the morphine in almost every patient who are having the emergency cases. Okay, because we need to deal with the severe pain with the patient, right? So morphine. Now with the morphine we need to monitor the patient as well. Okay, so most of the patient, they are in the emergency department or they are in the ICU department. Okay, so why we need to monitor the patient if you are giving the opioid or morphine like drugs? Because it is having the side effect. For example, respiratory depression may happen, bradycardia may happen, blood pressure might decrease, the patient might fall into the category of shock. Okay, so these kind of things should be linked up to the, you should monitor the patient. Fine. So naloxone, naltrexone, if the patient is coming up with the opioid poisoning, they can reverse this situation in just a minute. Okay, it can reverse the situation in just a minute. Okay, so whenever you're giving that intravenously, in the acute poisoning of morphine or in the acute poisoning of opioid drugs, naloxone you can give intravenously, and then it can be maintained by giving the naltrexone orally. Okay, so once you give the naloxone, you save the patient, and then you can give naltrexone orally to detox the patient from the opioid poisoning. That's why naloxone is the antidote. Naloxone is the antidote for opioids. Okay, naloxone is the antidote for opioids. Okay, and naloxone we are giving that in intravenous form. Okay, so I'm talking about the opioid poisoning. Let's talk about the actions of the opioids, how the opioids are, they are causing what kind of effects. So why the opioids we are taking? Only indication is about pain. Okay, it is reducing the pain, and if the intensity of the pain is so high, we are using that in the hospitals, opioids, right? What kind of side effects can appear in the patient? So starting from the head, we are having the CNS, right? From the CNS, it is giving you the analgesic effect. Analgesic means pain relieving effect, right? So analgesia effect. Then it can give you the feeling of euphoria and dysphoria. What is euphoria? Happiness kind of feeling. Because of happiness kind of feeling, the patient is on addiction. The patient wants to take more and more opioid drugs. Okay, so the patient is addicting. So let me talk about those effects also. Shall I rub this one? Okay, so let's talk about the side effects of these drugs, or you can say the actions of these drugs. In the CNS, it is giving the effect of analgesia. Okay, it is giving the effect of euphoria, dysphoria. Okay, if some kind of patient is on, if some kind of patient is having the coughing, it will be helpful in those situations because it is inhibiting the cough centers. Okay, so they are working as antitussives also. Yeah.
These are side effects or main effects?
These are some of the side effects. Look, this can be considered a side effect. This can be considered a positive effect. Rather, you should say over here the effects, the pharmacological effects. Okay. Which one? Yeah, it can be. Yeah, it can work as antiemetic because it is having the tendency to inhibit the coughing centers inside the CNS.
But antiemetic only in the first time.
But if the person is having vomiting, it doesn't mean the patient should take opioid. Yeah, if the patient is coming up with the coughing, then it can heal the cough also because it is inhibiting the coughing centers. Okay, but the antitussives, first line drug, you should be using, for example, dextromethorphan. Okay, fine. So this is for that one in the CNS effect. Then coming over to the eyes. Yeah, that will be causing the meiosis. So pinpoint pupils can be seen in the patient. Okay, meiosis. So meiosis is pinpoint pupil. Okay, there is one exception with the promidol. This one with the promidol, this trimipridine. Trimipridine, instead of doing meiosis, they are doing mydriasis. Okay, instead of doing meiosis, trimipridine or promidol, they are doing mydriasis. That is one exception over here. So okay, and rest of the drugs, whether it is partial agonist, whether it is opioid agonist, or it is opioid antagonist. I'm not talking about opioid antagonist, but the opioid agonist, partial agonist, they are causing what? Meiosis in the patient. Trimipridine is causing the mydriasis. Okay, remember that. Then third one is your let's say cardiovascular system. In the cardiovascular system, it is decreasing the heart rate. So bradycardia may be seen in the patient. If it is decreasing the heart rate, then blood pressure will also drop. So decreased blood pressure, we can say hypotension. Okay, so that can be seen in the cardiovascular. Respiratory system, the respiratory system, what may happen? Shall I rub this one?
Suppression.
Yeah, so respiratory depression is happening. And if I'm talking about the respiratory depression, which kind of respiration can be appreciated over there?
Cheyne-Stokes.
Yeah, Cheyne-Stokes respiration. So respiratory system. Okay, there is the respiratory depression, and Cheyne-Stokes respiration can be seen. And do you remember the pattern of Cheyne-Stokes respiration? So if this is the baseline and this is normal, and if I'm talking about Cheyne-Stokes respiration, right? Apnea, and then this cycle will be repeating like this. Okay, so first of all the patient starts to breathe, first of all there is apnea, and then the patient starts to increase the respiration rate, and then it is decreasing, and then again apnea. So this kind of form is the Cheyne-Stokes respiration. In the pathophysiology we have already discussed about that, right? Types of respiration. Okay, so Cheyne-Stokes respiration can be seen. Okay, with the GIT system, what can be the effect? In the GIT system, it can lead to nausea, vomiting, as other drugs. Nausea, vomiting. With that, they can cause constipation. Okay, constipation. And one more thing, the patients who are taking the opioid, they're having the problem of developing the addiction, and they're having the problem of developing the tolerance. What is tolerance? Tolerance means if some person is taking the drug, okay, with the particular period of time, they need to increase the dose for getting the same effect. Okay, if the patient was taking, let's say if the patient was taking 50 mg of drug, 50 mg of opioid for 1 week, okay, and his problem is solving. For the following next week, if he is taking same kind of dose, the patient will not get the relief. So he need to increase the dose. Let's say the patient should be taking now 60 mg in the second week. So what is happening? Tolerance. What is happening over here? Tolerance is happening. Understood the meaning of tolerance? Now tolerance will be seen in various kind of symptoms. For example, if the patient is taking, for the euphoria, dysphoria, inhibiting coughing center, bradycardia, hypotension, all the things, tolerance is happening. But meiosis and this constipation, they are not showing the effect of tolerance. Okay, meiosis and constipation, they are not showing the effect of tolerance there in the opioids. Okay, what is the meaning of not showing the meiosis? For example, if the patient is taking the same kind of drug, meiosis will be continued in that manner. Constipation also will be continued in that manner. Okay, but if I'm talking about the bradycardia, okay, if he was taking 50 mg of drug, bradycardia was not there. In the next week also he is taking same amount of drug. Now bradycardia problem is not solving, which means bradycardia is showing tolerance. Okay, so that is the thing. So meiosis and constipation, you will not see the tolerance over there. Remember that. Okay, so next property in the GIT. One more thing, we are having several kinds of sphincters inside the GIT. For example, biliary sphincter, from where the bile comes out of that. Okay, so the sphincters, they are having the problem in the relaxation, the patients who are on opioids. So the bile problem is there. If the bile will not be coming out from the gallbladder, let's say, or if the bile is not coming into the duodenum properly, will you be able to digest the fatty food? No. So that is also the problem in the opioid patient. Okay, fine. One more thing, bowel stagnation is happening in the patients. Bowel stagnation means food will be remaining inside the bowels and peristalsis movements are decreasing. Okay, so bowel stagnant will be there in the GIT system. Understood about the GIT? Okay, now let's talk about the genitourinary system. In the genitourinary system, what will be happening? You are having the urinary sphincter in the urinary bladder, and then sphincter should be relaxing for the urination process. Those sphincters are not able to relax over there, so the patient will be suffering from urinary retention. Okay, so in the genitourinary system, you can see there is the urinary retention. Okay, so that much effect can be appreciated in the patients who are using the opioid drugs. Okay, fine. So these are the effects. What can be the contraindication whenever the patient is coming up? So if any kind of patient is coming, you should not give the opioid directly. Let's say the patient is having the problem in the kidneys or the liver, renal failure cases there, or renal failure or liver failure cases there, head trauma patients. Okay, yeah, hypertension patient, respiratory depression patients, cardiovascular system depression patient, you should not use these kind of drugs. Or thyroid deficiency, adrenal gland deficiency, you should not use opioids in those kind of patients. So what are the contraindications? Because sometimes question comes, very good scenario will be given, but in the first line, second line, they will be giving the case that the patient was having the head trauma. Okay, and we are having the tendency to skip that, and we are looking for the other kind of things. For example, bradycardia is there, and all the opioid poisoning signs are there, and we'll be choosing the opioids over there. But head trauma is the contraindication. So mainly, if the patient is coming up with the head trauma, then we should not give opioids in those cases, right? So about the contraindications. Contraindications for the opioids. So head trauma patients, they should be avoided from the opioids over there. The patients who are having the respiratory depression, the patients who are having the serious depression, the patients who are having the deficiency of thyroid or adrenal gland, right? The patients who are having the hepatic failure or renal failure, okay, kidney or liver failure, these patients should not be given the opioids in those cases. Okay, fine. So that was about the opioids. So in the opioids, let's just recap the opioid. Opioids are the narcotic analgesics. They are also called as narcotics. Mainly we are using these kind of drugs in the hospitals mainly, not in the home. The thing is, they can cause what? Addiction. Okay, and de-addiction from these drugs is quite it is quite hard to cause the de-addiction in the patients. So first of all, we talked about the mechanism of action of these kind of drugs. We talked about the nociceptors, right? Pain receptor, how they are taking the sensation from the target organ up to the brain. Okay, so with the help of nociceptors, they will be reporting to the spinal cord, okay, dorsal root ganglion of the spinal cord, and then they will be taken up by the help of ascending tract, that is the lateral spinothalamic tract. Okay, lateral spinothalamic tract, and they will be giving this sensation up to the thalamus. From the thalamus, they will be going to the cerebral cortex, and that's how you will be able to know that where that pain is. Sometimes what happens is you will be able to localize the pain. For example, this person, this finger is having some kind of cut, so that is the sharp pain. Okay, so you can localize the pain. Sometimes you are having the pain that you are not able to localize. For example, this portion is having the pain, right? So that is happening on the localization, on the proprioceptors and all these things, but pain sensation is there. So in the pain sensation, we are having three kinds of neurotransmitters mainly, that is the glutamate, substance P, and calcitonin gene related peptide. Substance, so first of all, glutamate, so action potential will be there, then glutamate will be coming out in the synaptic gap. From the synaptic gap, it is having the chance to bind to which receptors? NMDA receptors and AMPA receptor. NMDA receptor, if they will be stimulated, calcium influx will be happening. If AMPA will be stimulated, sodium influx will be happening. They will be causing the depolarization. Then further, substance P is having the chance to bind to the neurokinin 1 receptor. If the neurokinin 1 receptor will be stimulated, that will be stimulating the protein kinase C. Protein kinase C will be removing the magnesium ion which was covering the NMDA receptor. That will be removing from the site of the NMDA receptor. Then again, calcium influx might happen, right? It will be leading to what? Depolarization again. Then we were having one more thing, that was calcitonin G related peptide, CGRP. That is having the chance to bind to CGRP receptor. If that will be binding to the CGRP receptor, what will be happening? Yeah, that will be changing the machinery of the neuron, and that can initiate the process, that can activate the process of depolarization over there, right? Then we know that we are having the opioid receptors also. These are the serpentine receptors, G inhibitory receptors, right? Now they are applying as a brakes on the pain sensation, right? So we are having the endogenous opioid, that was endorphins, enkephalins and dynorphins. These are the endogenous opioids. We can support these opioids by giving the drugs, that is the exogenous opioid. For example, we can give what? Opioid agonist or opioid partial agonist, right? In the opioid agonist, we are having the fentanyl, morphine, trimipyridine, methadone and codeine like drugs. Okay, one more you added, that was pentagocin, right? Partial agonist, buprenorphine. Okay, it is partially stimulating what? Mu receptor, helpful in the withdrawal symptoms of the patients, right? Then we were having the opioid antagonist, that was naloxone, which was giving the IV. Okay, it is acting very fast. Within a minute, it can give the relief to the patient. Naltrexone, it can be following therapy that can be given orally, right? Okay, among these drugs, trimipyridine is very important because I told you the several effects of the opioids. That was in the CNS, it was giving the analgesia effect, euphoria and dysphoria, that was causing the addiction in the patients, inhibiting the coughing reflexes. That's why it was acting as an antitussive also. In the eyes, it was causing a miosis. But miosis is not seen with the trimipyridine. Trimipyridine is a promidol that was causing what? Mydriasis instead of miosis. Now, promidol is very wonderful drug. Promidol is we are using the promidol in 3 conditions. If we need to use the opioids, we are using the trimipyridine or promidol in 3 conditions. What are these 3 conditions? So, if I am talking about the promidol now, promidol can be used in 3 situations. What are these 3 situations? First of all, it can be used in pregnant ladies. Pregnant ladies, because this is the exception. If you need to use the opioid drug, however, we usually avoid the opioids. But if you have to give, then you will be choosing what drug? In the pregnant ladies, in the pregnancy, you will be using the promidol. Rest of the drugs in the opioid classification, they are contraindicated. Okay, they are contraindicated because they can show teratogenic effect in the fetus. Okay, so pregnant ladies, pregnancy, you can include the pregnancy in the contraindications of the opioids, right?
Why does have an exception?
No, it is designed like that. It is designed like that. So it is causing the promidol. That's why it is unique in the classification of the opioids. Okay, so instead of causing miosis, it is causing the mydriasis. Instead of having the contraindication of pregnancy, we can use the drug which can be helpful in the pregnant ladies. Okay, one more thing, it can be used in the dislocations of the joints. So joints dislocations or fractures. Okay, joint dislocations and fractures. Now one more, I told you if the patient is having the problem in the hepatorenal, kidney or liver problems are there, you should avoid the opioids because they are contraindicated. In the renal colic patients, we can give promidol. Okay, in the renal colic patient, we can give promidol. So promidol trimipyridine is quite a wonderful drug if you talk about the opioid classification. So it can be given in the pregnant ladies, it can be given in joint dislocation fracture cases and renal colic patients. Okay, then we come to know about the opioid antagonist, antidote, naloxone, naltrexone. Okay, so that was about the opioid drugs.